Good afternoon, everyone. My name is Erica Haller-Stevenson, and I am the Senior Program Analyst for Chronic Disease Prevention at the National Association of County and City Health Officials, and I focus on chronic disease and tobacco.
Good afternoon, everyone. My name is Diana Kosmatic, and I am the Senior Analyst at the Association of State and Territorial Health Officials, and I also focus on tobacco and chronic disease prevention. We would like to welcome you to today's interactive webinar, Exploring the Use of Electronic Health Records to Support Tobacco Cessation and Million Hearts. Cigarette smoking is the leading cause of preventable death and disease in the United States. The use of electronic health records can play an important role in improving health by supporting tobacco cessation efforts. Heart disease and stroke are the first and fourth leading causes of death in the United States. Heart disease is responsible for 1 of every 4 deaths in the country. And Million Hearts is a national initiative that has set an ambitious goal to preventing 1 million heart attacks and strokes by the year 2017. The impact will be even greater over time. Million Hearts aims to prevent heart disease and stroke by improving access to effective care, improving the quality of care for the ABCs, focusing clinical attention on the prevention of heart attack and stroke, activating the public to lead a heart-healthy lifestyle, and improving the prescription and adherence to appropriate medications for the ABCSs. During today's webinar, we will explore and identify opportunities for using electronic health records, also known as EHRs, to improve 2 of the ABCSs of Million Hearts: smoking cessation efforts and improving blood pressure control. Furthermore, we will provide a state and local example and available resources to support these efforts. We will introduce each of our speakers before they present on the call today. All phone lines for participants have been muted during this webinar. So if you have a question for one of our speakers, please post it to the chat box on your screen at any time during the webinar. These questions will be used during the Q&A after today's presentations. At the conclusion of today's webinar, you will be directed to an evaluation survey. We ask that you please take a few minutes to provide us with feedback on today's webinar. We really do look forward to hearing your comments. In addition, a recording of this webinar will be posted to the NACCHO and the ASTHO website within the next few days, and we will provide the addresses for these websites on the last slide of today's presentation.
Thank you, Diana, for giving us some background information about today's webinar. We are joined today by an esteemed panel of experts who will be telling you individually more about their specific roles in tobacco control and/or strategies for clinicians to improve population health. Before each speaker, we will provide a brief introduction. We anticipate that there will be many questions for our speakers, so we have made an effort to allot time for that at the conclusion of the panel presentation. I now turn it over to Katie Potestio from ASTHO, who will introduce our first speaker. Katie, go ahead.
Thank you, Erica. It's my pleasure to introduce to all of you our first guest speaker, Rudy Federici. Dr. Rudy Federici is Director of Community Health Clinical Integration at Cheshire Medical Center, Dartmouth-Hitchcock Keene, a community hospital and multi-specialty physician practice located in Keene, New Hampshire. Rudy previously practiced obstetrics and gynecology for 16 years, but relocated to New Hampshire and has since 2010 taken a non-clinical lead role in organizing integration efforts that purposefully and proactively link clinical services with community health partners and resources. He serves as a member and lead for the New Hampshire team in ASKO's Million Hearts State Learning Collaborative and participates in activities that ensure continuing progress on the goal of making the Monadnock region of southwestern New Hampshire the healthiest community in the nation by 2020. We are thrilled to have Rudy Federici with us today, and Rudy, I'll now turn it over to you for your presentation.
Thank you very much. I'm thrilled to be on the call today and sharing what we're doing in New Hampshire with the rest of the country. I think if I had a theme for the next few minutes, it would be to be optimistic about what's possible. We've been very fortunate in our work here and have had some real measurable successes, and I wouldn't want anyone to get off the call today and not really be confident that you could do some of the things we've done here and have the same success. As was mentioned in my introduction, our community is in the midst of a very aspirational effort called Healthy Monadnock 2020 to become the healthiest community in the nation by the year 2020. And the work that I describe here that's aligned to Million Hearts has obviously also been part of our work to become the healthiest. So when we talk about whether it be hypertension or tobacco, these touch a large segment of the population. In New Hampshire, we have a similar burden of hypertension as the rest of the country. About 1 in 3 adults have high blood pressure. And of course, with tobacco use, it can be something like 1 in 5 adults. So these are issues that touch large populations. They also, both conditions, offer an excellent opportunity to integrate the work of the clinical care system with the public health community. And you'll see that that's exactly what we do and have done. So in New Hampshire, we were part of the MultiState learning collaborative that ASTHO and Million Hearts created, and since October of 2013 we've been involved in various projects with the list that you see in front of you of partners, be it the partners at the state, but also the University of New Hampshire, the public health departments of Manchester and Nashua, as well as federally qualified health centers. Our work has since been spread and now is involving other practices throughout the state. It also involves some atypical partners that I would recommend you consider when you're looking to do collaborative work, and one of them is the New Hampshire Medical Society. That group has been a very strong partner. They help us to produce some patient engagement tools, some wallet cards that patients can share as engagement tools. But the New Hampshire Medical Society has been very cooperative, and I think every state would have a medical society that could be approached for the sort of work that you're doing. My institution is Cheshire Medical Center, Dartmouth, Hitchcock, and Keene. We're a small, rural acute care hospital and multi-specialty clinic. Our county is about 77,000 individuals. We care for a population of patients, about 12,000 of whom have high blood pressure. And for many years, leading up to 2012, we had mediocre results in our ability to control high blood pressure in this population. We were in the sort of mid to high 60% of our patients being in adequate control. But in the beginning of 2012, we undertook a very proactive and purposeful integration effort to involve our entire medical staff and as wide a community group of partners as we could. And over a course of about 16 months, we were able to increase our hypertension control rates for our population of these 12,000 patients from this high 60 to low 70% to 85% control of our population. And here it is now a year later in the end of 2014, and we are still maintaining control in the mid 84-85% range. So as I said about optimism, I mean, I think there were certainly sort of defeatists who believed that we were doing the best we ever could do. 16 months later, we're in the mid-80s, and we were awarded a CDC Million Hearts Blood Pressure Control Champion Award in 2013 for this work. So I think it's folks should remain positive. As part of the collaborative ASTHO project, we created a very pragmatic, very simple 10-step manual on how clinicians and communities working together can improve blood pressure control at a similar degree that what we were able to do here at Cheshire, but what we've always also been able to replicate in the federally qualified health centers that we work with. This is a free document. It can be obtained online, and the link is there. It can also be obtained in hard copy. and ASTHO would have the links for that. It's a very, very practically conceived guide, 10 simple steps that any practice can institute. And 2 of those steps are pertinent to the electronic health record, and those are the ones I'm going to highlight now. So step 6 turns out to be the use of provider data dashboards. And I find myself, I'm an obstetrician by training, but for the past several years I've been concentrating on the Healthiest Community initiative that we're part of. So I haven't been practicing clinically, but I remember enough about being a physician that one of the qualities of some physicians is that they believe themselves to be geniuses. And it's a hard belief to shatter, but it's amazing what data will do. So one of the things that is possible using most electronic health records is to categorize patients and their outcomes by providers and provider panels. And so one of the first things we did was we created in this case, hypertension, but it could be just as easily used for the outcomes around diabetes, or even screening outcomes like the provider's panel compliance with pneumococcal vaccine or influenza vaccine. But it could also be things like the number of patients or percentage of patients who've had adequate tobacco cessation counseling and been referred for evidence-supported care. But when you use the EHR and compile a dashboard by provider panel of the experience of the providers, invariably we find that the providers are confronted with their true data. And when we did this back in the beginning of 2012, not one of our providers had a control rate above 78%, even though each of them independently believed they were doing the very best that they could do for their patients and were using the very best care that they could provide. The manual talks about algorithms and guidelines and triage protocols, things that we were not using back in 2012, but that we do now. By the end of the project, or I say the end of the project, when the project reached its point in June of 2013, we only had one provider of more than 20 who had a blood pressure control number under 78%. So in a relatively short amount of time, the dashboard in some way contributed to folks understanding their real effectiveness, and I think drove some behavior that improved care for everyone. So we use this very transparently. It exists on our intranet site. Any employee would be able to see this. So it's not just hidden to the clinical providers. It's not just to the individual provider's team. It actually is something that everyone, we have 1,400 employees, any employee could potentially pull up this and see how the provider's doing in relation to blood pressure control. And I think that's a very powerful thing to be transparent about data. The other step in the booklet that I think highlights the use of the electronic health record is a patient registry. In this case, the health record can be used to capture and field-define categories of the health record. It can be to capture individual patient experience with whatever health condition outcome, screening expectation like mammography or pap smear, as well as outcomes with whether patients are tobacco using or not, whether patients have scored high on a falls assessment or a depression screen. It allows a provider to see his or her panel of patients from a population view, rather than individual patients, one in front of us in our office in an individual office visit. This allows a provider to see his entire panel, his or her entire panel, and to see where the gaps are. And we have hired here at Cheshire registry coordinators. And on the slide, you see the typical workflow for the coordinator working with a provider to often interact with dozens of patients in the course of a very short time, like 1 hour. And this has become a very powerful way for the providers and the care coordinators, and the registry coordinators in collaboration to interact with many patients in a short period of time in a very proactive way to close their care gaps. We also instituted a free blood pressure clinic in our nurse clinic where any patient who's identified as needing to be brought in for a blood pressure check, there is absolutely no cost barrier or time barrier to that now because they can walk in anytime or be encouraged to come in by the registry coordinators. And the last piece of this is I think other practices are familiar with registry coordination and the use of registries. And our registry coordinators are not nurses. They're not credentialed health providers. They're actually chosen as our very best reception staff. What we realized was that the best registry coordinator is the person with the best interpersonal skills. And so we're able to, we have 4 who are every day work with our providers to interact with patients who need to be seen, haven't been seen, are still having challenges with their compliance with care or control. And it just turns out that folks that are very good at being empathetic and motivating with people turn out to be the best registry coordinators in our practice. So this is not a clinical role. To finish up, I just wanted to touch on 2 other things that we do here at Cheshire that I think are very simple but have been very impactful, and that has to do with tobacco cessation and control. We happen to have in New Hampshire no county level health departments like every other state probably has. We don't have that in New Hampshire. We have 2 city health departments and a state health department, but when it comes to our own county, the community health department in our county is actually a division of our hospital system. Otherwise, one wouldn't exist. So we're a little bit different so that we have tobacco cessation specialists, and they are employees of our hospital system. But I think in every other community, they would exist somewhat external to the health system. And in our case, we feel like we're external to the health system because we're in a separate setting distant from the main hospital and clinic building. And using the electronic medical record, we did 2 things. We instituted a simple 1-button tobacco cessation referral such that providers could simply interact with their patients about their tobacco use and then with 1 click of the button refer that patient directly to our cessation specialist. Now we've always had ways to refer. We used to have tear-off pads, calls that the receptionist at the medical office could make over here to community health. There were always ways for referral, but every one of them was cumbersome. This is 1 click and it's done, and we've seen our provider-initiated referrals to our cessation specialists go from an average about 6 or 7 per month to about 70 per month. So we are starting to interact with hundreds and hundreds of patients that we wouldn't have otherwise because of the simplicity of the electronic health record solution. And the other thing that we've done is we have created a cessation template such that our cessation specialists can document their experience with their patients in the electronic health record that then is shared back with the medical homes and individual providers such that any documentation is really now reciprocal and also immediate. And again, in our case, our cessation specialist is employed by the hospital, not the provider group, and yet has been credentialed to be able to use the electronic health record in this way. And I think, again, if we had been an independent community health department as part of a governmental entity, that same arrangement could have been created by our IT folks, and a cessation specialist could be allowed access to our electronic medical record in order to chart reciprocally. So those are some of the things happening in New Hampshire. We're always willing to share. We've borrowed most of the things that we do from somewhere, and we're happy to share back. So my contact information, feel free to contact me, and I'm happy to take questions at the end of the webinar today. Thank you.
Thank you, Dr. Fedrizzi, for your comments today. We appreciate you sharing the great work you're doing and the successes in New Hampshire. I want to remind our audience that we will have questions for the entire panel toward the end of the webinar, but you are welcome to submit your questions in the chat box now. We're beginning to organize them for our speakers. I'd like to welcome our next speaker, Shannon Farley. Ms. Shannon Farley is a tobacco evaluator and the acting director of the Research and Evaluation Unit in the Bureau of Chronic Disease Prevention and Tobacco Control, part of the Division of Prevention and Primary Care at the New York City Department of Health and Mental Hygiene. Ms. Farley is involved with multiple evaluations, including grant-funded activities related to smoke-free housing, as well as evaluations of tobacco control policy and implementation in New York City. Ms. Farley is pursuing a doctorate in public health at the City University of New York. She completed a Master in Public Health at Columbia University and a Bachelor of Science at the University of California, San Diego. Ms. Farley has lived and worked internationally on health and education-related projects. We're pleased to have Shannon Farley with us today. Shannon, I turn it over to you.
Thank you very much. I'm really glad to be here today to share our experiences with you all. As long as someone will put my slides up for me and move them forward since I don't have access, I'd really appreciate it. Thank you. So today I'm going to talk about a collaboration. Actually, can you go back to the first slide? Yeah. About a collaboration between my bureau and the Primary Care Information Project, which is another bureau here at the Health Department, that help to increase documentation of smoking status, as well as the number of smoking cessation interventions conducted at community health centers here in New York City. All right, next slide. So the Primary Care Information Project, or PCIP, was started back in 2005, and it was to support the adoption and use of information systems like the electronic health records, EHRs, to improve the delivery of clinical preventive services among the primary care practices that specifically provide health care to underserved populations. State and local data have demonstrated that Medicaid enrollees had a higher smoking prevalence in the general population. With our 2011 New York City data, we saw that almost 19% of New Yorkers with Medicaid insurance were smokers, compared with almost 15% of New Yorkers in general, and that was a statistically significant difference. And so to help address this disparity, we implemented a program that we called Health Equips, and it was designed to increase cessation interventions with ambulatory care centers. Health Equips was a pay-for-improvement program that incentivized the large community health centers to conduct the cessation interventions with their smoking patients. And centers were eligible to participate if they had been using EHR for at least 1 year. And this project was funded by the CDC's Community Putting Prevention to Work grant. Next slide, please. The CPPW grant ran between March 2010 and March 2012. The participants had to have their EHR system in place for at least 1 year, and then we retrospectively collected the prior year data to establish the baseline smoking rate and the provision of cessation services rate for the year before the intervention for all the different centers. The intervention required that providers document smoking status in the EHR, and that they document the provision of one of 3 methods of cessation intervention, either counseling, prescribing cessation medications, or referral to the state Fax to Quit hotline. And then for each additional smoker receiving an intervention above baseline, the practice received $20. And our goal was to reach an additional 18,000 smokers with an intervention, with this intervention. Thank you. So at baseline, and then for each quarter, data was obtained from each center using the EHR, and we got the total number of patients that had at least 1 visit to the center, the number of visiting patients that had a smoking status documented, and the number of smokers receiving at least 1 cessation intervention. And in addition to providing them with a financial incentive, the centers received a quarterly report based on the data they provided in their EHR. The report showed the practices how much they earned that quarter, how much they could have earned that quarter, a summary of the data on the number and proportion of smokers receiving interventions, how many opportunities they missed, and some comparison information, including the average and the 90th percentile performance of EQUIT's participating centers. And as Rudy just mentioned, this sort of report dashboard was really helpful to the health centers in seeing what they were and weren't doing, and some of them really ran with it, and it was very helpful for them. Program staff visited and called the practices to follow up and troubleshoot data extraction issues when they were needed to. We could provide provider-specific reports, upon request. Usually we provided them for the whole center. And we did provide training for center providers and staff as on request. New York State funds cessation centers throughout the state that provide coaching on motivational interviewing and other resources to assist smokers with quitting. So we partnered with them for this project as well. Next slide, please. So this is a display of what a provider would see if they were using the eClinicalWorks EHR software here. 9 of 19 participants used other systems such as NextGen, Epic, or Allscripts. And for users of eClinicalWorks, that right pane is a typical clinical decision support that lists several clinical preventative services a patient is eligible for during the encounter. And as you can see circled in red, the smoking status is one of the preventive services that will be highlighted if information on a patient's smoking status hasn't been completed in the past year. And this CDIS was programmed to show the annual smoking status screening. So we put that in, we added that into what was already in eClinicalWorks for this project. Next slide, please. So if the provider proceeded to use the CDIS for smoking, and a form will appear and a list of questions that the provider should ask to determine whether the patient's a current, a former, or non-smoker. And then if they're a current smoker, more questions will be shown. And we like using these structured fields to gather the information because it allowed us to generate the smoking status reports for each center. Because if they enter the information in these fixed fields, it recorded the data and it made it easier for when you wanted to extract the data and analyze it, because it's really hard to find the information when it's in a free text field. Next slide, please. So then once the questions have been answered, the alert won't appear again for another year. And then what's not shown is that if the provider hasn't intervened with the smoker, an item will appear for smoking cessation intervention. So if the provider proceeds to cessation intervention, they'll be able to take an order set, like a shortcut, to allow the providers to deliver and document one of the 3 interventions, either counseling, prescribing the medication, or referral to the state fax to quit line. Next slide, please. So here's some data on what we found, is also what was published in our MMWR. In the sample overall, the number of baseline patients at each center ranged from a low of around 600 to almost 125,000. And there was a wide range for the proportion of Medicaid patients at each center. From some practices had none, some practices were mostly Medicaid patients. The baseline smoking prevalence was just under a quarter of all patients, and it ranged anywhere from 0 to 75% of patients being smokers. And we feel that these lower baseline smoking rates might reflect the failure of practices to systematically screen all their patients for smoking, or that the reporting might have been done in unstructured fields that we couldn't capture with the EHR. And at the end of the intervention, the mean smoking prevalence was 27%, with 68% of practices increasing their proportion of documented smokers. Next slide, please. So at baseline, 23% of smokers had received at least one cessation intervention, and this rate more than doubled to 54% by the end of the 18 months. And all but one center had an increase in the number of cessation interventions. So more than 5 times the number of smokers received cessation interventions during the 18-month program period than during the baseline year, and we ended up being able to give out $220,000 in incentives. We did cap the amount that each center could earn at $50,000, And we more than exceeded our goal of reaching an additional 18,000 cessation interventions above baseline. We got an additional 30,000. Next slide, please. So for visual people, we've got a figure that shows the number of documented smokers in the dark blue bars, and then the number of smokers with interventions in the light blue bars. And then that black line going across there is the intervention rate for all 19 practices. And as you can see, both smoker documentation and interventions increased over time, with the rate improving more for the later quarters of the intervention. And what we learned was that it was important to emphasize smoking status documentation. Providers were much more likely to intervene if they had documentation of the patient being a smoker. Next slide, please. So EHRs can make things easier for providers by integrating the documentation needs directly into the clinical workflow and allowing for easy provider referrals to state quit lines. They make it possible for the providers to get rapid and frequent feedback on how well they are following through with the screenings and interventions. And this can help with motivation for improving outcomes or identifying areas for future improvement, and to ensure that the providers receive the right reimbursements. I mean, Medicaid does pay for cessation interventions and up to 6 months of medication. So by tracking these bigger picture health outcomes, the data can be used to provide evidence to the healthcare systems and policymakers that cessation interventions do reduce smoking prevalence along with smoking-related morbidity and healthcare costs. And the role of EHRs has a lot of potential for growth going forward between the Meaningful Use Initiative and the Affordable Care Act. Increased documentation of smoking status and more cessation services can be delivered. Next slide. So our project did have some limitations. There wasn't always EHR data available from a couple of the centers, either for the smoking screening or the specific cessation intervention used. We were unable to assess effectiveness of the cessation interventions in this study. Instead, we were focusing on documentation because we felt that that was what needed to be sorted out first. The study was solely based in New York City, and the results may not be completely generalizable to other jurisdictions. And we were also unable to separate out the changes due to just modifying the EHR versus changes due to receiving the incentive payment. And additionally, New York City has many population-based tobacco control activities going on at the same time, which may have also contributed to the changes in the cessation intervention. And in conclusion, EHRs alone are not going to improve cessation interventions, but when clinical workflows are considered, as well as incentives, and providing assistance in maintaining quality improvement, clinical interventions like healthy quits can supplement the ongoing population-based tobacco control and provide a means to reach the more difficult-to-reach smokers with opportunities for cessation support. And then the last slide, my email. Feel free to contact me. There's more about work that we do here in New York City at the newyorkcityreach.org website, and thank you very much.
Thank you so much, Shannon, for such useful information and telling us about all the wonderful things happening in New York City. There's lots of questions that are already coming in that are being directed toward you, so I just want to remind our audience members that if you have a question for Rudy or Shannon, please go ahead and put it into the chat box. And we're organizing those questions, and we will address them to our panelists momentarily. Now we wanted to move into sharing some resources. We would like to begin by sharing resources available from the Office of the National Coordinator and NACC, the North American Quitline Consortium, who are both unable to be with us today. No matter where your agency may be in the development of an EHR process or implementing a process of referrals, the healthit.gov website contains resources that may be useful. On this website, there is a tab for providers and professionals. And under this tab is information that explains the steps to take toward EHR implementation, achieving meaningful use, and where to get local technical help. In addition, there is a tab that shares success stories and case stories. As an aside, You may also find assistance from your own state's Meaningful Use Coordinator. This individual would work in the 3 primary public health measures in immunization, syndromic surveillance, and also electronic lab reporting. We also wanted to share with you information from the North American Quitline Consortium. NACC is an international nonprofit member organization that seeks to promote evidence-based quitline services across diverse communities in North America. Quitlines are telephone-based tobacco cessation services that help tobacco users quit. NACC has established a work group on e-referral to ensure that all state quitlines are prepared to implement e-referrals with healthcare providers no later than the year 2016. NACC works with the healthcare system and also EHR vendors to make sure that they are informed about NACC activities. As of February 2015, the NACC work group on e-referral is comprised of members from 6 states, quitline service providers, and healthcare partners. The work group has been busy and produced 11 case studies on quitlines, service providers, and healthcare partners engaged in e-referral projects, and they published a paper on e-referral in 2012. Currently, a technical guideline on e-referral is being developed and will be available to NACC members in the spring of 2015. For more information about the work group or e-referral for quitlines, please contact NACC. Their web address and a contact email has been provided to you on the slide.
We would now like to share some resources available from NACCHO and ASTHO that support state and local health departments in tobacco control and achieving the goal of million hearts. I will begin with sharing NACCHO resources. NACCHO has a number of resources that can be used by local health departments to support their tobacco and informatics efforts. Each subject area has a web page that serves as the best place to begin looking at our resources. NACCHO maintains a searchable online toolkit containing tobacco and informatics resources from across the country, including guidelines, fact sheets, and model policies. You can contact NACCHO through the tobacco or informatics email addresses posted on your screen, or through my direct email address that will be shared at the end of the webinar. NACCHO also creates and disseminates Million Hearts resources to local health departments and their community coalitions. These resources may be found on Million Hearts webpage and range from the webinar series to a local engagement guide, toolkit, and model practices focused on using Million Hearts campaign. You may contact the chronic disease team at NACCHO or me directly, again mentioned at the end of our webinar.
ASKO also has several resources on our website that may be helpful for states. The first is a comprehensive tobacco control guide for state and territorial health officials. This publication includes examples of the work across several states that they're doing in the areas of tobacco control and prevention. ASKO also has written comment letters on proposed tobacco control regulations, including issues like menthol and e-cigarettes. And in addition, you will find on our website a summary document from a comprehensive coverage roundtable meeting hosted by ASKO with key recommendations from experts. The web address for ASKO's tobacco website, where you can access more information about all of these resources, is up on our screen now and also on the last slide of the presentation, along with my contact information.
ASTHO also has lots of resources to support states with Million Hearts. To help achieve the goal of Million Hearts, ASTHO's Million Hearts State Learning Collaborative is using a framework of rapid cycle quality improvement to drive the work of states and territories toward creating systems for improved identification and treatment of hypertension. In our new online toolbox called the Million Hearts Tools for Change, ASTHO has compiled tools and resources to support these efforts. The tools are organized by categories, some of which are shown on your screen: community clinical linkages, data-driven action, evidence-based programs, financing and policy, and standardizing clinical practice. These resources include the New Hampshire manual that Dr. Rudy Federici mentioned in his presentation, along with many other state-developed materials. ASTHO also has an interactive map of activities and state-developed tools from all 15 participating states, Palau, and the District of Columbia, who are involved in our ASTHO Learning Collaborative. The resources on the map include descriptions of the state's activities and also highlights of their work, such as protocols, provider and patient education materials, referral forms, and manuals. We hope that you will use these resources and share them with your colleagues as well.
Thank you, Katie. We're about to enter our Q&A session. I will remind participants that the slides and the recording will be made available on both ASTHO and NACCHO's websites within a couple of weeks. You will be able to check back through the information or refer someone else to watch the entire webinar. We will be asking questions of all of our presenters today, so I ask our presenters to perk up their ears and be ready to listen to our questions. And we're going to start with a few for Rudy in New Hampshire, and then I'll go back and forth between everybody to try to keep it interesting as much as we can. There's a possibility that we might not get to every question with the time that we have available, and if that does occur, we're going to create an index of all of the questions we received to see if we can follow up with those that were not answered. The first question is to Rudy. He asked, we have a participant who asked, how did your providers react when you created the dashboards and made them public? How was it received?
So one thing I didn't mention is that we are an integrated health system here. The hospital and the provider group are under one umbrella, and all of our providers are employed. So that's different than if the folks were coming from competing primary care practices across the community. These folks are captive in that they're all being employed, so that helped. I would say honestly, because we started in a very stepwise way that the manual will describe in terms of getting provider ownership to this issue, and certainly the providers were interested in improving their hypertension control, it wasn't as much of a problem as you might think. There were folks who thought if this is likely to be an effective way to encourage friendly competition and call out high performers so that those high performers might be able to describe what they do that seems to be so successful. I think the few low performers that we had initially sort of overcame their shame or something and allowed this to happen. Now with all the providers exceeding most of their colleagues throughout the country, I think they're happy to display their current results. So it wasn't as big a problem as we imagined, but we also have an employed practice here, and so it may be different in competing practice environments.
Thank you, Rudy. And a little bit of a tag-along question for that. Looking at how you develop the buy-in by the providers for the dashboard and the receptionists to serve as the registry coordinators. Healthcare practitioners typically are practicing at the top of their license, but sometimes there's resistance to this type of delegation of responsibility.
So thank you for bringing up the top of the license concept, because I think it is pertinent to this issue. There are a few things also that were foundational to this work. One is that we are a site for the CMS Pioneer ACO model pilot, and so the practitioners know that they're trying to achieve the triple aim in terms of achieving the best outcomes at the highest quality, but also lowering cost. And so the idea of cost is in the back of their minds. They're actually incentivized to do better, to have better hypertension control. So there's a incentive for them to do whatever necessary to improve their own panel's control. And I think we have been very clear about this idea of working at the top of your license or ability. Even to the point that we've remade our local medical homes to look a little different than other medical homes. We actually have a role called collaborative care nurse, where we have RNs actually providing some protocol-based direct care to patients with stable chronic conditions. So we already had sort of a history of innovation when it comes to using whomever is capable of doing some of the work. The question of ownership or buy-in, though, one of the very first steps to our process here when we first launched our hypertension quality improvement, and the one step that would be step one of the manual, is to actually engage your providers and nursing staff in a collective sort of survey of why they believe control is not as optimal as it could be. And that's a very powerful tool to use, because when you're done with that survey and you analyze the results and you come back to the providers and nursing staff and say, here's what you perceive as some of the barriers the patients experience or you yourself experience in getting inadequate control of your panel. Many of the items that they point out are exactly the items that we then implemented, and so there was almost a co-authorship of what we ultimately did by starting with this, asking the provider and nursing staff to tell us what they believe. And so you'll see that answers will come out that there just aren't enough staff to touch all the patients. There just aren't. I'm not having much help in my day-to-day activity with the patients, and I need help. And just things that we then came back and said, well, then we're going to create this registry management coordinator for you to give you the help that you asked for in the survey of challenges. So.
Thank you, Rudy. One more question for you before I switch over to some questions for Shannon. How many tobacco specialists do you need to handle the 70 referrals per month that you receive?
So I should say that we obviously also, I saw some questions came across that had to do with, well, aren't you sort of in that every patient, every time, every referral, all that? We're very, and maybe it's the culture here, is we consider readiness to be an important aspect of the care. And so even if there was an electronic medical solution where a patient could potentially walk in the door and a scanner identify that patient as a tobacco user, and instantly the EMR sent out whatever referral or fax was, that wouldn't be the way we would approach it. We would want there to be sort of a motivational interviewing-like interaction between patient and caregiver, and ultimately the choice of now is the time for referral to be made in a shared way with the patient. So the reason we don't have 700 referrals a month is because we're finding that 70 right now seems to be the number where the patients agree in their conversation with their provider to pursue a cessation experience. All of our cessation experiences are face-to-face, and we do employ right now just one full-time FTE as a cessation specialist. So that one individual does our inpatient cessation interactions as well as one-on-one interactions with the patients that are identified. And there's obviously patients can self-identify, patients can be captured in different support group environments throughout the community. So the provider-initiated referral is not the only avenue to get access to our specialist, but we've just added a second one this past month, so now we would say we're up to 2 FTE.
Thank you, Rudy. I'm going to ask a few questions of Shannon now. Shannon, you mentioned that the funding for the project that you presented that was documented in the MMWR article was funded by Community Putting Prevention to Work Fund. Did you use any other funding to pay for the incentives, and have you continued to pay for incentives since that time, and how do you fund that?
So the entire project was funded by the CPPW grant. All the incentives were funded from it, and no, we have not continued to provide incentives because we didn't have the funding for it. Basically, what it boils down to.
An unfortunate case, often in public health.
But hopefully, those practices that started using the EHR for documenting their smoking and their cessation interventions are still continuing. And I know we have plans to look at that data. We just haven't had the opportunity to do so yet.
Great. And is it correct that you used the EHRs to track the data, or did you have to use a separate database?
No, we use the EHRs, and then we do an extraction of the, usually overnight, so it didn't disrupt their system during the day, and we pull the data out and do the analysis here at the health department.
Great. Does your screening include tools for other than combustible tobacco types of products that are used?
I apologize. I am not in the EHR side of this project, so I've only seen what's on the screen, and I don't think so. But I think that's definitely something that can be modified within the EHR, just working with your EHR provider.
Great, thank you. And then an interesting question came in reference to healthcare providers operating really outside of the immediate practices where you were conducting this intervention. Say you have patients with a dentist or some type of specialist. Are they able to access these EHRs, or is the access limited to a certain circle of providers?
So I think the way it works is whatever health center you're a part of, that's the group that can access, within your own EHR. I know that there are some dental practices that use them, and I know they're working on getting them more involved. If someone has follow-up questions, I can put them in touch with the correct people to answer these questions because it's not me. But unless they're linked through whatever their organization is, then no, you can't.
Great, thank you. In your community, following this intervention or during the process, did you find that the system-level intervention resulted in a similar or even higher degree of change for disparately affected populations?
So, yes, that even the centers that had high proportions of Medicare patients or patients with mental health issues or substance abuse issues, they also had higher rates of interventions, cessation interventions by the end as well. So it did work across all different kinds of practices.
Thank you. You mentioned that your patients who were focused on during your intervention were ages 18 and above. Was there a rationale for not including people under 18?
That's a really good question, and I don't know the answer to that.
That's okay. That was probably in the early part of the behind-the-scenes work.
Right, yeah. I came into the grant a couple months after it had gotten started, so some decisions had already been made, and we just moved forward with everything.
Great. I have a question that might be a little bit more directed to Rudy, but Shannon, I welcome you to respond if you find it applicable to your experience as well. How far along are you with pediatric EHR systems to help deliver treatment and referrals for parents?
So I would say, the same system that we use for all of our patients is the one EMR that we use, and it's in our case it's all scripts. There are many different vendors of that. I would say that we are not yet. The EHR is very good for documentation. I'm not sure it has yet been used to anywhere near its potential in terms of outreach, engagement of the individuals, clients themselves or their families, and we struggle with that also. So my guess in pediatrics, although that's not where I spend any of my time, is that it's a terrific tool for documentation. It obviously things like recording BMI and things of that nature we do very well. But in terms of using the EHR in some way to provide outreach to the families themselves about their children's health needs, I think, like many institutions, we probably fall short.
Thank you for that. There's a question for you, Rudy, asking if you could describe the tobacco cessation template and its use slightly more in depth. Is it used with every patient who is a tobacco user? Have there been any impacts demonstrated as a result of the use of the template?
So the template gets used only by our cessation specialist when she interacts with a client who's been referred to her program. What I would say that it has done is when I open my comments about this concept of optimism, there's a certain challenge in the health arena around satisfaction with work, I think. I think there's been, over the last couple of decades, I think it's been getting harder and harder to be a healthcare provider in terms of the burden of work, in terms of the business of medicine. And part of why our hypertension work was so fulfilling was I think every provider and every nurse throughout our institution took credit for the progressive improvement in hypertension. And I think in the same way, as the EHR and the cessation work in terms of tobacco is sort of becomes ever more effective, I think everyone gets to take credit for cessation. So the fact that our cessation specialist is charting in the EHR that she can task the provider who referred her to ensure that that provider reads her note, and especially when there are successes, when she's able to say this patient's gone 6 months without smoking, this patient's gone a year without tobacco use. I think it changes the internal sort of mental conversation many providers have of, I have no success with this. This is impossible. I've asked every patient I know to quit smoking and they never do. And they're starting to see by us replying back into the medical home that in fact you have a lot of patients out there who are getting better using the supports that are external to your practice. So it's not on your shoulders, but thank you for that referral and that initial encouragement of the client, because look at how far they've come. So I think it allows for the sharing. The template's powerful and it allows for a sharing of success, and I think that drives further referrals and more optimism within the clinical setting, and so that's part of it. But right now, if a physician or a nurse practitioner would see a client and decide that they were capable of doing an entire cessation intake and intervention, I'm not sure they're pulling up that template, even though it would be available to them. I think they would chart that in a more traditional note that they're more familiar with.
Thank you. I'm going to pitch a couple of questions to both Rudy and Shannon and to see if either of you have answers for this. I'll start with Shannon, and it applies for Rudy as well. Somebody from Southern Indiana is interested in using the screening questions and information for their providers at their area hospital. Is that reasonable from your perspective from each of your jurisdictions?
Maybe to share and use the same screening questions? I don't see why not.
Thank you. How about you, Rudy?
I think just like the manual initially, because it was a New Hampshire effort and we happened to title it, Improving Blood Pressure Control for New Hampshire, it makes it sound like somehow it wouldn't work for the other 49 states. And I think everything is adaptable and customizable, and my guess is that just like we borrow good ideas but not necessarily exactly in the same format, I think there are always things that would be shared across context. So I think most things would apply throughout this country.
Thank you. Rudy, while I have you on the phone, have you had any payers take interest in supporting your intervention?
I saw that question come across also. It made me think of two cost questions, because that makes me think of finding revenue to support this and things. One is in the Million Hearts Learning Collaborative that we've been doing since October 13. Anthem Blue Cross Blue Shield has been a partner as well, and they're the biggest commercial insurer in New Hampshire. And so right now it's not yet reached that point, but they're at the table, understanding what we're doing, liking the results that we're seeing, in some ways helping us imagine what data that isn't capturable in the electronic medical record but might be capturable in the third-party payers' IT systems, and how could those complement each other. I mean, those conversations are happening. So I would invite the major third-party players to the tables across the participants today, saying don't exclude those folks. We all have probably shared interest in doing this work at higher value. The other question I saw come across that I think is worth talking about is, the capability within a practice to do this sort of thing. You know, how do you afford to create a dashboard? How can you make a registry? And we did take, as an institution, a registered nurse with an interest in analytics and IT, although not formally educated in that world, but with an interest, and sort of made that person a super master user of our EHR, such that she can both generate reports in real time, like registries or dashboards, but she can also manipulate the EHR to create customized templates for whatever the health condition to make it easier for clinicians to chart. So having that capability internally was, I think, a great investment. And so I know a lot of other practices often have to wait for a vendor to create a document. Sometimes there's a lag in terms of the time that a document's created and the last care experience. In our case, we can create them in real time because we have someone dedicated to that work internally.
Thank you, Rudy. Shannon, since your intervention, have you noticed any payers interested in supporting additional interventions?
Not that I'm aware of.
Thank you. Yeah, you probably would have been right on top of it if they had, right?
Right, yes. There would have been a lot of talking. People would have been very excited had we heard about that.
Great, thank you. A question to Shannon, and then I'll use the same question for Rudy. Is there a mechanism in your EHRs to follow up in relation to a patient who uses tobacco and is given cessation counseling or resources? Also, is there a prompt to screen them and follow up with them in subsequent years?
So the question will pop up, it gets asked once a year, basically. So if you go in on an annual basis, it'll pop up every year. So that way the doctor will be reminded to follow up about whatever happened the last time. Did that answer the question? I'm sorry.
No, that does answer the question. Thank you. Rudy, how about for your system? How often are your providers prompted to screen, and do you get any prompts about follow-up?
Well, I would give a similar answer in that the system can be created to prompt across every client in the system, such that if you wanted a yearly reminder that every patient should be asked every year, that will prompt. But depending on where information is placed in the EHR, and right now we're considering adding tobacco use, for instance, as many have, to the vital sign list, which is prompted of every intake of every patient at every visit. So there's ways to create the prompting in a customized way, and then there's a way to set it sort of as a general default for the whole system. And so I think those things are, it's often amazing when we ask a question of our IT folks, boy, we would love to be prompted every 3 months about this group of clients. How often the answer is, well, we can do that, and yet the provider wouldn't have known that. You have to sort of ask the master user who knows what's possible. So I think some things are customizable and some things are tricks, such as putting it into the vital signs that ensures that it's asked and prompted at every visit.
Thank you. Rudy, did you experience any challenges or successes in having to customize the algorithms and queries used to identify your key populations across different types of EHRs? I think you mentioned you use one system, but what kind of was your experience in developing those algorithms and queries to get that information available for you?
So in some ways, because the in hypertension, which I'm more familiar with perhaps because of the project, depending on the outcome measure you're using, in our case for Million Hearts, it's a National Quality Forum measure of hypertension. It sort of defines what hypertension, how hypertension is defined. So it cares about the very last hypertension measurement that was obtained. It tells you the population with which you're trying to screen, in this case 18 to 80 or 18 to 85. And in some ways the algorithm that's created matches the the question you ask, and often that question is defined by the definition of the measure itself. So in a way, when we create these registries, our data, I'm trying to think of the right term. I think her term is, she's the data, I'm forgetting her term, but she would actually take the measure, take the definition of the measure, and that's what algorithm she would load when asked about how folks are in terms of compliance with mammography, or in terms of compliance with pneumococcal screening, or their blood pressure control, and whatever. And she designs the algorithm to the definition of the measure. And so folks that are good at that can do that, and it's a very logical approach, but it allows for an ever more robust registry. When we started, we just did a hypertension registry, and all we cared was, are you in or out of control? And we wanted to be able to communicate with those who were out of control. Now we have a registry that probably has more than a dozen different care points that when our registry coordinators interact with that client, they're not missing an opportunity to discuss screening or immunization or smoking cessation or whatever other gap is necessary to be discussed.
Thank you, Rudy. Shannon, I have a question for you, and this is just based on your experience with this intervention. Why do you think that tobacco cessation messaging and reminders are not standard for all EHR programs?
Honestly, I think that it might just be because they hadn't been thought of before, that it wasn't part of, as we were just talking about, the traditional vital signs that are in the system that you get asked about every time. And I think that it's something that will probably be explored and expanded on going forward now that people have started talking about it more.
Rudy, do you have additional comments on that question regarding why tobacco cessation messaging and reminders are not standard for all HRs?
Well, here's what we've actually gotten ever more sophisticated with expecting more and more from our EHR, and what the vendors tell us is that when the EHR was designed, it was designed to do a great job of documenting care and keeping that information secret. It was meant to be a really good electronic locked file cabinet, just like we used to have when we did paper records and they were locked away at the end of each day. And now we're asking of them that, just like my cell phone can tell me where the nearest Starbucks is, they want the EMR or EHR to do all this prompting and reminding and data analysis and data capture, and it just isn't what they were designed for. And so I think in some ways we got exactly what we asked for 20 years ago when the first ones came about, which was make me very secure ways to capture data and keep it from peering eyes. And now we're asking a lot of it to say, no, don't do that. We really want that to be a tool with which we can do incredible outreach and proactive care. And I don't think that's what they were meant for. So I think a lot of these aftermarket solutions are partly because that wasn't what they were intended to do. They were intended to simply document care and do it in a secure way.
Thank you. I have one more question for Rudy. Was it difficult to gain consensus on prioritizing hypertension as opposed to other issues in your network?
So that's a great question, and it's 100% intentional that it was hypertension first. And the reason for that, and why I would encourage any practice who has done very little of this or has very little success with this to pick hypertension first, is it touches a third of the population. Even diabetes, meaningful in our community, it's around 9% of the population. Even tobacco use in our community is around 18% of the population. So there's not any other thing that touches a third of all adults. And the other thing about hypertension is truly in 4 to 6 weeks with improved compliance to medication, improved behavior change, often just coming in to have your blood pressure repeated and have a more favorable blood pressure obtained, because we're now using a very evidence-supported approach across our campus and across our community and taking a blood pressure in an evidence-supported way. Being in New Hampshire and having a horrible winter this year, it would not have been unusual 2 or 3 years ago for someone to come in with a sweater on and have the intake staff put the blood pressure cuff across the sweater and try to take a blood pressure, for instance. when you're doing things like that, your blood pressures are inaccurate and you're not even getting the correct reading. So those would be sort of the things, I would say.
Great, thank you. Those are all of the questions posed by the audience. We do have a couple of very specific questions that we actually want to connect Jonathan and Mary for their questions with some people who can help them directly because they're so particular. So we're going to do that in follow-up to this webinar. And then I'm actually going to ask each of our speakers, Rudy and Shannon, if they have any closing thoughts or remarks that they'd like to share with the audience, reflecting on their entire experience. Why don't I ask Rudy to go first, and then I'll ask Shannon to follow.
The question around why hypertension, whatever this very carefully designed process improvement, if it's understanding the EHR better, if it's creating direct order entry and direct referral, if it's templating notes so that they can capture exactly what's necessary about a interaction, all of those things are transferable to every other chronic condition as well. So in our own institution, yes, we have the 10 steps to improve hypertension control. We had great success. We're right now in the midst of how do we do the same thing for hypertension. We had also done the same thing for COPD. It turns out that these same concepts of collaboration with community, registry management, patient engagement, protocol and evidence-supported triage and treatment guidelines, all of those things transfer into better care for any condition. And so we've been fortunate. We've seen actually a really remarkable decrease in respiratory-related readmission and admission after doing a similar project with COPD and asthma. And it's the same comprehensive use of effective protocols and practices as well as more effective use of the EHR. So I would just say, just because the webinar today is titled, Tobacco and Million Hearts, I think it works for most every condition that we all have to try to confront.
That is fascinating. Thank you, Rudy. Shannon, what closing remarks and reflections do you have for the audience?
Well, Rudy is a tough act to follow, but I definitely agree that this is using your EHRs in these different ways to put in reminders, track different outcomes, is definitely something that can be done. And I think it's a matter of talking to the people who run your EHR and finding out what it is that they can and can't do for you. And you have to have good communication between them. There has to be someone that understands how they work, like Rudy was talking about, his super user who knows what's possible to help the practices get what they need out of the system. I think that we saw a lot of success with our project, and I know that we're interested in expanding this type of success in other areas to help improve how EHR can help providers provide better service to their patients.
Thank you, Shannon. I want to remind our audience that the story from New York City is actually featured in an MMWR article by CDC from the fall of 2014. I believe it was October, but it's a very easy search to find, so you can get some more specifics on that project. I also want to remind our audience that while we could not have a presenter from the Office of the National Coordinator on the webinar today, they have a lot of very useful information on their website, and you can find ways to obtain assistance to implement EHRs in your community, but all about achieving meaningful use and getting local technical help. Their website is healthit.gov.
And on that note, we want to thank you all for joining us today. As we mentioned earlier, you will be immediately directed to an evaluation at the conclusion of today's webinar. We want to ask that you please take a few minutes to complete our survey, as it really does provide us with useful information for future projects. ASTHO and NACCHO would like to thank the CDC Office on Smoking and Health for sponsoring today's webinar. And we want to pay a special thank you to our speakers, Dr. Rudy Fedrini and Shannon Farley. A recording of today's webinar will be available on our website for the next few days at the web address shown on your screen now. And we hope that you will use this webinar as a resource and that you'll share the link with others once it's available. If you have any follow-up questions about today's webinar, please don't hesitate to contact the team at NACCHO or ASTHO, and we want to thank you and hope you enjoy the rest of your day.
For those on the line still asking about where to get the slides, use the 2 web links on the final slide. Those go directly to the tobacco pages for ASTHO and NACCHO. You can go to either organization's website and you'll find the recording and slides there in a couple of weeks. Thank you.
And we'll also send it out as a follow-up email to all the folks that have registered for today's webinar, and it'll direct you to the specific web link as well. And on that note, thank you and enjoy the rest of your day.